Now, for now, my question of the day, maybe Sao say, Ube date will be Ogusuni now 40 and now, at what age cry and see if you are 14 9 quiet cotton? I say, I say, would 25 years now, no 40 day red flag, 30, 35. So I didn't try to send text mama 0243909909. Now, also good morning, please. How are you doing? Competition. I'll say, please, I need a car to work and pay. Okay, Mate. Let's run work after the show. Met me anyone kasawai. And Dominic from Kolebu said, for the question of the day, leaving your parents as a guy while dating is not good. I think he meant to say leaving with your parents as a guy while dating is not good. Or to us to say, I always say as a guy, be on your own before you enter into a relationship. But a lady can live with her parents and still be in a relationship. Now say money, they say come and kakra because hey. When you say hi, how are you doing? Let's all send me a message and I'll do it. Maybe I'll text me if you account na FFF. A phone lines in there maybe multi mobile say maybe I not just say question me I will be some because me come my ready say metie asem e bia na we experience no e come out ye e bia odi an come out ye. And it's time for the health talk segment na ene. Some I ever come once a minute, meaning so beating you because and also you're the Arabian. So I'll be having a conversation with Madame Anne Bentel. Which I wouldn't say me personally in go for dear daddy, I like it. Anne Bentel, didn't say or butcher say if you are coming never told you. By a palliative care nurse specialist, I will wage by municipal Lakaway Hospital. Because a palliative and also the Arabian as a day. You ever born home come on. There's your question be 18 no question be no text him was 0243909909 Matume Boise Ebusat your mouth for fair. Even though I know say special. Anybody when no one to search it. Anybody so when anybody where everybody patriotic and come in mommy why you ready and so ready. Good morning madam, welcome to the show.
Hi, good morning.
Okay, I hope you're doing good this morning. Oh, I'm fine, thank you. Yeah. So, if someone is hearing about palliative care, because
thank you so much for the opportunity.
All right.
But before I start, if I say make her say, give glory to God Almighty for this opportunity.
Okay.
I also want to thank the staff and management of Ojagbawi Municipal Hospital.
Okay.
The management of Breeze FM for this opportunity.
Okay.
My heartfelt greetings to all Ghana Palliative Care Association members listening to us today, and my family as well.
Right.
Okay. See, palliative care no, enya abo ebidin.
Okay.
Palliative care a branch of medicine.
Okay.
A branch of medicine which has been in existence for a long time. But it was introduced to our part of the country, or our part of the world, let me say Africa, in the late 90s.
Okay.
So it's a branch of medicine that started in the United Kingdom by Dr. Cecilia Saunders.
Okay.
Yes. So this is how it started. If you don't mind, a brief history.
Okay. Briefly.
So until now, or a nurse, or started as a nurse, a very young nurse.
All right.
Married to a Polish man. A Polish man on Burma or Poland. Now, Papa,
no, be uncle Casa the Polish fan who.
I was a
yeah, that's so true.
So at a very young age, she lost her husband.
Oh, so sad.
Yes, she lost her husband by cancer.
Okay.
So she was left to care for the husband. So when the husband was dying, he left her £500.
Okay.
To start a hospital or a health facility where she can care for people like the way she cared for her, for him before he passed.
Wow.
Yes. So that is where palliative care started from. So we say in a nutshell, like, not to bore all of us, palliative care is an aspect of medicine that doesn't care for just cancer patients, but patients with life-threatening illnesses, who are very serious illness. They say, oh, wait dear, and I say, I see, wait dear, if I better so I know kakranka, kanya de benya no drama or says, ya ben and kakranka, can I share?
Okay.
If I say who say medicine has not entirely given up on you.
Okay.
There is a branch of medicine that is here to comfort you.
Right.
Like the way Breeze FM is comforting us. That is here to comfort you and help you through.
Okay.
So that if you have to recover, yes, we'll help you through recovery. But if it's going to end up in death too, we'll make sure we will nurse you or we'll take care of you to a comfortable death. So in a nutshell, palliative care is about quality of life.
Okay.
Improving the quality of life of patients and then their families living with life-threatening illnesses. Utie na mekaye na me say patients and their families.
And their
So
families.
it is not restricted to just the patient.
The patient, yeah.
So this branch of medicine is concerned about the family. We involve you in the care.
Right.
So nebe ya umbeka say obu obeda hospital sa or say oba ekwa ye hu yare ya see ye no. This is the branch of medicine and we also inculcate spirituality.
Oh, okay.
Yes. So not just the physical aspect of care, the spiritual aspect of care, the emotional aspect of care, the social aspect of care.
Okay.
Yes, is what palliative care is all about.
All right. That's amazing. So why is palliative care an important part of healthcare?
Yes. So palliative care is very important because it serves as the bridge
Okay.
between patient care, family, the hospital, or the medical team.
Mm-hmm.
So when we have, let's say, a patient,
Mm-hmm.
okay, and you don't know what is really happening to your patient, this is where palliative care comes in.
Okay.
And like I explained already, we give holistic care.
Okay.
So holistic care, we give psychological, we give emotional, we give social, we give spiritual. So we give holistic, like I said.
Okay.
And then we also do pain and then symptom management.
Okay.
Life threatening. We do stage, there is no cure.
Okay.
We need to manage this patient so that the patient's quality of life is improved.
All right.
So that is when we come in. We come in with the patient's goal of care, especially na patients nebeka. Obeka so sisi ade me bread do. Ebe ya mommoa me. Muntimi nyehwe ma me kra mommoa me na ebia ye wa me komu. I don't want to die struggling.
Okay.
I don't want to die gasping or asking for it like I'm struggling before I die.
Okay.
I want to die comfortably. It will surprise you to know that there are people who want to die. Let me say they are unconscious patients.
Okay.
The patient is unconscious. The family knows that this patient wants to go,
Okay.
but the patient cannot go. So then we have to break it down. We have to go and then do our assessment, psychosocial assessment.
Okay.
And in this part, then we ask the patient's relative, in same be with fear, and maybe with fear, so this, we are not only concerned about the physical aspect, only the medicine side. No, we are also concerned about the social aspect. And then it really helps in a lot. Sometimes you'll be surprised our patients are able to accept their diagnosis.
Okay.
And then if they have to go through recovery, fine, go through recovery with them, their medicines, everything. But if they have to pass to, like I said, they die peacefully.
All right.
Some people even die with a smile on their face.
Wow.
Yes.
That's amazing. So you talked of cancer. Wakaso will be or cancer will be to be because mean shadante maybe issue here. Who can benefit from palliative care and at what stage of their illness now this particular care is introduced to them?
Thank you very much. So palliative care started, Medica explaining Cecily Sanders from cancer.
Right.
Okay. So when the late 90s I started now HIV/AIDS cases that led to a lot of mortalities. Because mortalities are death.
Death. Yeah.
In this part of our world, that is Africa. That is when palliative care was introduced to Africa.
Right.
So yes, HIV/AIDS and then started in Zimbabwe, then Uganda, then to Africa, to Ghana, to Nigeria, and other parts of Kenya, and other parts of the African countries. Yes. So and palliative care can be started at the beginning of the diagnosis.
Okay.
At the beginning of the diagnosis, into medical kind life-threatening illnesses, life-threatening, we'll go deeper into those ones. Yes. So as we go on. So at the beginning of the diagnosis, yeah, and try my doctor and can't just there she knew why a bit to me and son I catch also there is no hope for you.
Okay.
I go started palliative. No. Palliative starts at the beginning of care.
Okay.
Once you've been diagnosed with a life-threatening or serious illness,
okay,
like a life-threatening or limiting illness.
Okay. All right. So you talked about giving emotional care, psychological care, and all that to make us understand better. Give me a few examples. What are the services that are typically included in the palliative care? Okay.
So before I go to the services, I want to name a few number of diseases so that people are not restricted to the HIV and the cancer alone. It's cardiovascular diseases, congestive heart failure, coronary heart disease, chronic lung disease, COPD, pulmonary fibrosis, cystic fibrosis, neurological disorders, Parkinson's, renal or liver disease, end stage renal or liver disease, infectious diseases like HIV I already mentioned. Okay. So, Sandy, you asked about the services. Yes. So, services they are grouped, and there are a whole lot of palliative care services available. So, for instance, we have the hospital. That is what I'm practicing now.
Right.
We have community-based. We have home care. Palliative. We have the hospice as well. So I cast a hospice now. Hospice no. So be for. Can be hospital no hospice.
Can be say obi be say new word for hospital new hospice na say Gen Z word for it. But your chima.
So hospice actually means or it's a term that is given to facilities where patients are have less than 6 months to live.
Oh.
Yes.
Oh, okay.
Yes.
Yes, aka busumi nsiana sabe we fi atiasefo asase so a na se ho na obetina. Okay.
Yes. And it's an aspect of palliative care. Just an aspect of palliative care. Because medical actually say palliative care starts from the diagnosis.
As now we can say no be aka 6 months na sabe obe film dey. As a hospice, that's a isolation bi wo mu ana. Anya ni sa.
Oh, isolation bia ni but there are facilities. You're not entirely wrong.
Okay.
There are facilities who take only hospice cases. We don't have one in Ghana for now.
For now, okay.
Okay, we started, but we don't really have one in Ghana like for now.
Okay.
But hospice no. Obuwa optise me pese me wu fie.
No.
Pese me call hospice. And the hospice they just say omo da ho keke a omo twen say
okay.
They engage them. Family is allowed to visit.
More activities, we say football in okay.
To keep them entertained according to their energy level.
Okay.
Yes.
Because you can't say joining other people more hospital. If you no binu be basketball be serious, be na affecting the energy level. Okay. All right. That's good.
Fatalities
Okay. Yes. All right. That's beautiful. Right. So how does the palliative care help manage pain and other symptoms? Say be onipa ne fan say serious pa mo man care na be energy level ni we need to drop it to maybe a hike it to 100 and 90 say na changes na at home.
All right, thank you so much for the question. So medical can say pain and symptom management as well as render support. We do other things too. We do bereavement counseling. We do respite care. So but to help our listeners to understand, our listeners and our viewers to understand very well, I want to restrict myself to the pain. Okay. So let's take pain for instance. Back in hospital, I'll say, and I say, oh baby, yeah, we are. We I started that pain. Okay, I tried drama one. This is where palliative care becomes relevant.
Relevant here.
Yes, in the patients who has the life-threatening illnesses. For instance, let's say cancer. Okay. For such a patient, they might be in constant pain. Okay. So palliative care will do the physical assessment, yes, but also we will do social. Okay. We will do emotional. Okay. We'll do psychological. We want to know how pain medications. So now It means that there are other things that we need to really delve into.
Okay.
I have patients who are semi-conscious. Obekomu na obebusia no say what happened, how are they, how is the relation, how is they. You realize that if that person is a mother, probably or uncle her and I say ne mabi or what, they are not the way I say uncle are bonding, they are not bonding.
Okay.
The person can see, say, I might not survive. I am going. So you ask them, talk to your mother, even though she's semi-conscious, the person can still hear you. Talk to that person, and you'll be surprised. The mourning will stop. In such patients, when they are groaning and they are mourning, that is when you know they are in distress, or they are in pain. Okay. So for such patients, yes. And then one aspect of the pain too that we have to look at is that palliative care does all round. We call it around the clock.
Around the clock.
Pain management.
Okay.
And try my number and sana ya catch or say for a drone. So for instance, around the clock, Nene say if you catch or say every 4 hours, make sure you take this medication.
Okay.
And if within this 4 hours, the panic complaining of pain now, please serve.
Oh, okay.
Please serve. We don't want our patients to be in distress. We want them to be as comfortable as they can be.
Especially those ones now, ABI affect your mind. You have to give them that kind of comfort. Okay. Ghana highway, Ayana baby, dream said, Sabia Casa Cocolebu, and I said, when you da so in asa. Because you say, honey, baby, a swan, a handle difficult cases. Where can people access palliative care services? Baby, a medical center be baby or hana or specific places be a access to that.
All right, thank you so much. Nietiane say palliative care started here no nanka kolebu. Nanka ebia
Confanoche.
Omo level of facility from tertiary facilities.
Okay.
It's all tertiary facilities. No, handle palliative care, but with time, I work at the district hospital, which are a municipal hospital.
Yeah.
We are trying to bring palliative care down to our people because we want the majority of the people to benefit from the care.
That's amazing.
Then our kind,
Take because be work it there, be one, but who is as a holiday or last stop in Tibet, Dean say, on Ukran here, one or better to Nanamos alcohol. Okay.
So what we are trying to do is integrate palliative care into the community through the districts, from the district level downwards. We want to get to a level where we are operating at the community level. We can come if you are in from a community, so we are coming every week. They can't afford to come to the facility.
Like in the long run, Cranky Biamba walking to homes or being here services no fee anchor will be great.
Yes, I'm really working at that one. I'm really working at that at the hospital.
Okay. All right, that's amazing. So how can patients or families request palliative care services? Phones no inquiries be and they have to bring the patient
Yes, so there are various services.
Okay.
So we have the home care. For the hospital, you have to come to the hospital.
Okay.
Sometimes we have patients who need to come for review. Or say they are by a baker say your lab kakra.
Okay.
You say kakra. Now you find review and you say do na is it really working?
Right.
So it depends on the service that you want to access.
Okay.
If you want to access the home service too, you have to call.
Right.
Come. I'll be the team lead because I'll be the palliative care nurse specialist. So we'll do our home assessments of your environment, of you yourself, your conditions, what you've gone through, how far you have gone, and then we'll come up with our plan and how we can help you.
Wow.
So for now, we are running the hospital-based and we're running the home-based or home care service.
I carry on my idea, because I like your demeanor, very calming. And you'll be a bear cocky, the diaco, nipani, a who near my the temperature and I rise it up. So it's it's really nice. But now, I can say, Sabio be a near so serious, severe, or be, if you could say it like that, and being here palliative care. But if I say, if I pregnancy as an example, I'll be a normal, very normal. When you need me up or abnormal in many ways, ultimately depressed and other things. Is it only people are more be unkwana some omuhia palliative care na obi a the issue no serious but affecting emotionally and psychologically. So betimi aba for services like that.
Okay, so for palliative care, actually we don't work in isolation.
Okay.
We work as a team.
Oh, okay.
So because a team approach, it means we have medical doctors, whether they are specialized or not.
Okay.
We have nurses, whether they are specialized or not. We have lab psychologists. So it's team work.
Okay.
But the most important thing is that it is the team is led by a specialist, palliative care specialist, whether a medical doctor or a nurse.
Okay.
Yes. So, for example, now say a pregnant woman, you know, medicine is dynamic, such that we've tried to break it down so that we are in a specialty.
Okay.
She said that if I'm focusing on patients with life-threatening illnesses, I'm focusing on them.
Okay.
If I'm focusing, so I'm looking at the medical side.
Okay.
But it will surprise you to know that sometimes when patients are going through depression at the surgical side, or a amputation, why depressed, onto me handle, or even for the maternal side,
okay,
we have palliative care for maternal.
Okay.
Hospital, I catch and say, ABR scan now, why NHS, Aklana, deformed, or condition, ABR. On China, the mother's demeanor changes. The mother demeanor changes. Sometimes they need us to intervene.
Okay.
We're always available to talk to them, to counsel them. Yes, to counsel them and then prepare them for what is ahead. If we have a condition now, let me focus on the pregnant women because you mentioned them.
All right.
So for the pregnant women, usually when a woman goes to the hospital and then has done the scan, and then the specialist, the obs and gynae specialist, has actually attested to the fact that the child is malformed or has a condition, maybe chromosome malcondition, and I bet me about said the child is even dead in the womb.
Okay.
So such things, you and I are women, we understand that it hits differently.
Okay.
It can just drain you psychologically and lead you straight into depression.
Okay.
So that is also an aspect of palliative care. I can come in as a palliative care specialist to care for that woman and render her counseling, not just her husband or any significant other that she wants us to talk to concerning the issue. So yes, it is available for pregnant women, but pregnant women in that category.
Okay. Yes. All right. So there are some myths. Say, say be a palliative care. No need to be here. Medications be and kofo believe so. We are sure say uni pay drug modi tata ni enya addictive. Ebi obefi mo care ni mukra be kone bia or abuse drugs ne kakra. No krebi womana.
Okay, thank you so much. For we call something myths. We call something misconceptions. Okay, so our thing is that why do you have to? Our principle is that no patient deserves to suffer.
Okay.
If you are in severe pain, there were categories of pain.
Right.
You were mild, you were moderate, you were severe.
Okay.
So, was severe pain? I'm mild paracetamol. I'm not helping you.
Right.
I have to be able to assess your pain to a level where I give you the drug that will match. Yes. And this addiction comes from opioids.
Okay.
A classification of drug called opioids.
Yes.
The morphine, the betadine, the tramadol, low dose. Exactly.
Yeah.
So this is where the fear comes in. But before we start, we call something titration. We titrate the dose to the level where it can handle or you can tolerate your pain.
Okay.
So we give it also be pain. Maybe I want the pain scale of 1 to 10. Or back also me pain that 3 I'm comfortable. I don't even need pain medication.
Okay.
Or when say unless ABI is around 7, 8, and I'm me here pain medication.
All right.
So we titrate the pain medication according to the patient's level of pain. And then we usually almost starts from the low dose and titrate upwards.
Okay.
Yes. So we try to use to stop overdose, not getting people addicted to their medication. But for palliative care, our principle is that we give you the medication because you need it, and we don't want to see you suffering. We want to improve the quality of lives of the patients in our care.
Okay. All right. And you can say in a few years or a few months to come, no, it will be down to community for people to access. But now you do when how can the community better support people living with serious illness? Because illness kakraya we cry stigma on honey account can't imagine serious one pano.
Thank you so much. Well, as the past about say as and I want to use this opportunity to talk this opportunity to be able to speak about stigma.
All right.
Sometimes we forget we are human. Sometimes you forget that the hands that you are pointing, the finger that you are using to point to somebody, three others are pointing back
to
at you.
So, yeah.
And to say, stigmatized, and now you are picking on somebody.
Yeah.
Please, let's be careful. Because today you are healthy, tomorrow
so.
I remember telling somebody that, today I'm not feeling too well. I say, hey, now want to so to me, Yari. Why won't you droning in answer so to me, Yari?
Also, a human.
To me,
because show monostress and I'm also Yari, so that's how it works. Yeah.
Exactly. Stress no crampo. I'll use this opportunity to speak to the public and then educate our listeners that stigma shouldn't be something. We should rather have compassion towards people who have life-limiting illnesses. Instead of pointing fingers, instead of show passion, let's help the person. Offer to help. Offer to bring them back. If you can cook, if you are a church and maybe you can help the person with food, organize weekend to help the person. Sometimes people don't even need anything, they just need you for you to come and sit down with them. Not to talk, just keep quiet and sit down with them. Even your presence is compassion. So we also talk about the gift of presence in palliative care. Let's make our presence not make people deranged, but we should let our presence uplift others. So I appeal with to our listeners, our community. When I say our community, the family, the church, the social groups, the friends,
even the school and Kotinan in China saying it's not nice. Yeah.
Let's show compassion. Let's show care. Let's try to help them and bless them with whatever that we have, rather than stigmatizing and pointing fingers at them.
Okay. Into Kabi say obi say na umpona. Only medre mu nana oyari. How do before I'm about challenge this one, how do caregivers manage stress and avoid burnout?
Okay. So caregivers the caregivers can be the caregivers, medical caregivers, I'm a care hospital.
Okay.
It can also be the people who are around the person now, more care for either family and also will be a or a caregiver.
Okay.
So for caregivers, no people say it was maybe you jam money pabako.
Okay.
Unquiet. Na ye bi say ko pescaba. We say me ko yesi. Me na me disikaba. We say me so me ma yesi. We say
do not in chain.
Yes.
There's a uni pabako no be bibia fiti beginning ko see end no. Okay.
And when the patient is in the hospital, we see it a lot. When I'm involved in your care, what I do is that I hold a family conference.
Oh, okay.
Yes, I hold a family conference. Let's call everybody.
Because obi ono mo obeka say o kwa na ye pe wa asem ti nko akọ and all that, but onipa ne obusu ni you have to support in a little way you can to also help omo moten in chen. Yeah.
Especially more working class
sectors no.
Yes, working class and our siblings. Sometimes not omeja atu say ye bema no yare or ban nko so. You know how the patients say, ma, me work and ho. She gets it. So I had to hold a family conference with the children.
Okay.
I say, I mean, I'm a body sikaba. Where say, okay, so now we are going to run shifts.
Okay.
The moment I said, you have to go to work in the morning. You have to arrange. You are 4. So be a better no one night moon rotate so na be a won kase won kwa what na
I don't have a bomb on nipa no yari because one bob because me ba we dia some pema sem wamba na onipa na etin ntia no be feel bad nso so no nkwa no hwe ni na take effect on them ntia na ye kan wan sem esro na was we tie bidi bia to koto dwem.
So we did it that way and I realized that the woman was okay.
Okay.
Because I'm sure we've ever had a situation only one person or tene maame ho onko fia wonko oda ne ho ese nyanum aka nyina wa brochi sika wo fie kakra yempe obi a ebia obetumi atena no na wonso ko na ko home mami si da bi da the mother died within a few months. I called so yes, so caregiver burnout is real.
Very real.
It is real. Inti me pam choma my fan is serious. So bi ti yare for ho a my eni nko yare for no nko so. Ya my eni nko nipa na ote nipa no so no ho. E kwan bi betimi aboa no no. Ya nya na ebo no. Say 3 hours for so betimi akwakoda obi nhwe no. Uti ya na kakra de obi nhwe no no so nye den. Enko home. Na ntimi fa enya akoma pan kwa fa nhwe mo relative no.
All right.
Mama.
Okay. Enti me meka yaka caregivers ni ho asem kakra pese e come also medical front no.
Yes.
What are how do you also manage stress? Because I'm also mudi ni biansa also o healthy conference. There's any spokesperson who be cheche musa for a long time and sakwa no asan be wan kasa wadwuma no.
Enye ese na making. Ebusuafo no enye omo beka bia wo beka. Ni o beka say ne ma 5 ne ma say to me man and you kunu ne and say ni wo fi no fe bad wo fi say and the excuses they be. But one aspect of caregivers for our young health workers, they said sometimes it is always heartbreaking when you have to break bad news or explain to a family or explain to a patient, say, if your prognosis is bad, the way we see it, you might we have to appear strong before you. But after we have broken the news and we go into our corner, you'll be surprised to me some of us be pain somewhere.
I've always been wondering, like, how do you guys gather the courage to do that? Because it's very, very difficult. To be better so sabi and you busu and intention and found but your job is to make them better. Then to me and court said you open and it will be very, very hard thing to deal with.
Yes, especially with palliative care where we have bonded with the patient and the family.
Oh.
You have bonded so well and your patient tells you that, sometimes you might think say it's actually good. Say the patient is being like, see, I want me. Another aspect of palliative care, we help the patients. We call something advanced directives, and then we also help them to be able to plan so that on you we're free more.
Okay.
Nyame amona se we free more nechi. Opo ha wo no kwa ha ne se nechi. Then e bisi wo nechi. Iti wa boa na na niama no. Say say I'm even ready for them. Okay. You as a provider, and we think say, I'm not providing so you have done your work so well. Your patient has even accepted, your patient has put everything in place.
Order.
Maybe you're fine, maybe you're okay, into no doubt better, but you'll be surprised. Just go and hide somewhere and then I have to let it all out.
What you may do? Let's 5 minutes be out to sad news there. And I say, akukudru pa. Nyame nkoso ma ahoden to me fire adwuma ne. Okay. Enti yehu se waka challenges ni bi kakra. Yehu se enye ade da from kra. Very difficult because e be sad say wo ho na da bia ye ka take your health and sense serious. Who find it serious na boni enko na boni abeto a na emu treatment nso de how baby bad ya na mo ya de yembo mabaso nti ansa na be kokra no finally e bia o advice bia na say o final words bia na afi yetie no.
So I'm grateful for this opportunity and I would like to person men can share yetie for you biara who have the opportunity to listen to this message that later. I want us to understand that palliative care is accessible and it is closer to us than we can imagine. Okay. And we shouldn't wait till ABI patient is at the end of life. And I say, you won't say, I really more idea into me before we start assessing palliative care.
Okay.
It's available we do home-based care at the facility. Once you come to the facility and you want to access palliative care service, it's available. You come into contact with me, and then we'll make the arrangements, and then go and see the patient, and then extend our care, and then use this opportunity to also speak about the gift of presence and avoidance of stigma. We shouldn't stigmatize people because of their illnesses. On penisa, it can happen to anybody. Oh, co-accident is see. One night, see a picture. You are deformed. People actually laugh at people with disabilities. It's wrong. People are then now our phone say Jama so Jama say you would never know. Now HIV patients come, but they don't walk around with the skinny. Exactly. So don't just assume.
Okay.
Instead of assuming and then stigmatizing, let's show compassion.
Okay.
Let's show care. And let's try to understand and put ourselves in their shoes. In palliative care, we say empathy.
Empathy.
Yeah. Let's have empathy towards our fellow human beings. Thank you.
Okay, all right. Now, Madam, answer now. Now, my question of the day, maybe say, will you date someone now? Ugusoneni mamete. A red flag and a green flag, mom.
Oh, okay. So, date. Me make say. Obi on any mamete, me oba.
Okay.
Obi on any mamete no. A dependent relationship I mean ipa kono wo. We go for this.
Almost no. A red flag and a red flag.
A red flag.
Oh, okay.
So we look at it in two different ways.
Okay.
So one, ohe nipa na what is saying. Me, I will look at nipa ne subain.
Okay.
Relationship I mean nipa ne wo, and how far we have gone in our relationship. People are very responsible.
Okay.
But the poor why be ne parents hono is closer to work.
Okay.
And the parents hono or why it will help him to be able to save up. So it depends on the relationship you have with the person. If the two of you are thinking of the future, you might consider. But when I say, hey, on mama net, you're responsible. I know, Gen Z
25 years, no mama net yade. And so that time not 25 years, Africa na already 18 no, abrabomu no.
Sister Sandy. So it depends on the two of you. So if the person is saving up, more worry be them when him.
Okay.
If I need to parents ho, okay, more worry I'm to me na ho. More worry you make plans. So why not the person save up on rent? Right. Save up on other things. And then I say more already say more baby worry. I pay more baby.
Okay.
Now what's na? Me dear. It's not a red flag.
It's not a red flag, okay. No. But it boils down to a nipa so the vision be one hand the way or handle in your man, okay.
Exactly.
All right. Stingy ni dear. I can't mo count. I know mo some year the one who. Then a man and Gen Z, a man and stingy. Now, when they are stingy, very dangerous.
My man be a stingy. So such a person who say and stinginess na man.
A man tifie. Oh, okay.
And yet the fact say abia or person save up towards a good cause that be and stinginess na man to go.
Menya ba ko account point ba ko account any me be phone lines na mesre mo. Mo be chechim de ntia.
Before we go, you know, this also what's in the parents on the crampono. You realize until hokwa. Or contributed towards rent, or contributed towards utilities,
okay.
Light, otia water, automation in your animal, a parent in your animal. So not necessarily say we're just responsibilities.
My parents, no. Okay.
There's no son, there's no abuse who is feeding off the
parents. Now, because it's already 90 years. Okay.
Red flag.
All right. Okay. Yate. Madam Annie, that's the son of Unya many a bonkomo.
Thank you so much for the opportunity.
Okay.
If I'm chief nursing officer.
Oh, okay.
Yes, CNMO Patricia Che.
Ni post ni so do so far. So that's Madam Ann Bento, who is a palliative care nurse specialist with Jaguar Municipal Lakaway Hospital. Ya bonkomo papa who say sometimes I really na work you. You ho no man na nidaso na sana ese kwa na ukọ. na say na so be continue ye mo na mo konimu no amunya asomdwe kakra ni je kakra mbra at the end anti stigmatization is one thing generally baby e wo and ye nya hu say pimples bia be si wanu bia person obeben because e be pie na so ni become obi hu e serious but e bia na ntisa ye show support ye mbo like communities wo busuani bi o sana wo ye busuani mpo na untimi support you no bi o abonten wo na obehya ase show na omo afoforo abonten so take you step no anti here say na be ye hu say places wo no ultimate access medical center for na busa enquire busa so say ni say na to me misramo ebi wa ha mbetimi ayi memoa na ye pepepe nkase kolebu eye bebi e ayi mhihye ntu hia mo ntimi nko asa wan kwa be den nya moa entenene nkomo ayi boy na madam anwe no say chale I live with your parents ni de umutu stingy for ni bo ho no stinginess nti opeso otena akodi 90 years e so wa for na wo but hey, it's Michelle. Minimum time to come and be phone line 0243909909. Maybe I was saying, hey, Kofi Yesu. I said, yes, no, I'll change my phone number. Hello, good morning.
Hello, good morning.
Jesus, brother, Passion, what to say?
It's young for the morning. I'll say,
oh, there she be now. So,
we question for the day in the day. Dia what's my main chain and as your parent chain hanum dia good because when you're 25
okay
20 and 26 now we hear now I so to me save you sika na we say to me so aye wo dia nti we bia wo worry about me akọ wo
oh okay
you my main chain abroad be how then would you think rent ni boy easy
and na make no pay you a very serious papa
easy to say when you nka hanu bo bra na to my main chain so be